Thank you. I am going to stand over here so I can see, but I'll be sharing experiences from a few countries in the region on actually screening for intimate partner violence. Next slide, please. But the question, first of all, is to screen or not to screen? That is one of the questions that we are still sort of contending with, and the evidence that will be presented in this presentation will hopefully bring us to an answer to that question. A recent paper by Jukes, which was published in 2013, was entitled The End of Routine Screening. Many of you here will be familiar with that paper, and it's an influential paper that was also highlighted at the 2013 SVR Forum in Bangkok. The paper basically says the critical question is whether screening, routine screening for intimate partner violence is worthwhile. Any activity based on the identification of asymptomatic individuals has to result in improved health status of those screened. The evidence now indicates that it does not. The time has come to conclude that routine identification of abused women and provision of a standard intervention is not the answer. So this was sort of the message that was relayed at the SVRI forum last year. So the next question is, so what are we all doing here talking about IPV screening? I think it's important to still be having this meeting and others like it, because this particular paper is really based on a review of 3 randomized controlled trials that looked at IPV screening. At least one of the papers, I've read one of them, not all 3, but in one of the papers, the authors do concede that had the ladies that were screened and identified as being IPV positive through the screening process, had they been referred to an effective intervention, maybe the results would have been totally different. So essentially, the authors were saying, well, yes, we screened women, we identified them, but we can't really say with any confidence that the intervention we referred them to was an effective one. So that was one of the 3 papers upon which these conclusions were based. And so what that means is there's still a need for evidence, right? Next slide, please. So does this mean that we should go beyond randomized controlled trials? I don't think so, not exactly, but it's important to understand what they bring and the gaps that they can also leave, so that before we make our conclusions on whether IPV screening is relevant for this region or not. I should also mention that those 3 studies were also based on developed country settings. This particular paper that focuses specifically on RCTs talks about how choosing between RCTs and other kinds of studies is really a non-choice. We need different kinds of studies before we come to conclusions. That's just the fact. And so rather than viewing data as competing, a more productive strategy would be to understand the value that each type of evidence brings. So what I would like to do in this session is present evidence from a number of different countries in the region. And these are not, these studies, their design, they weren't based on a randomized controlled trial design. Nonetheless, they provide valuable information that can help us understand what exactly is happening in our region when it comes to IPV screening. Next slide, please. One of the issues that have been debated is the fact that IPV screening maybe does not have much benefit. But experts are also talking about the fact that, what is benefit? How do we define it? Is it up to us to define, or should we look at benefit from the perspective of those who are identified through screening, whose voice should count? There are arguments that we need to consider more qualitative outcomes when we're looking at the issue of IPV screening. And there are arguments that being very patient-centered is important, and patient-centeredness is a challenge for randomized controlled trials to capture that sort of a concept. So we're not throwing one thing out and saying another thing should be privileged. We're saying let's hear both and let us make our conclusions based on a range of different types of study designs. Should we screen or should we not? There are lots of different barriers in the African setting. We're all familiar with them, which might suggest that we shouldn't bother to screen. But those barriers have mostly been presumed. Many of them have not been tested. They've been based on just what we observe when we go to clinics or where not. And so nothing has actually been proven. Let's go to the next slide, please. And so now we'd like to move beyond these just presumptions to look at actual evidence that's coming out from the region. I'll start with a study carried out in an urban setting in Tanzania, in Temeke District Hospital in Dar es Salaam. Very briefly, I'm just going to rush through this study and the next one. Providers were trained to carry out screening. They were trained to screen the first 3 clients that came each day over a certain period. To screen them for intimate partner violence, and they screened a total of 102 clients, and about 50% of these clients reported experiencing IPV. That study is by Lacer and Kasanga. I have the references at the end of this presentation, but the conclusion was that IPV screening by providers in Tanzania is feasible. Next slide. Another study in Kenya by Turan and Hatcher. We'll be hearing from Abigail Hatcher in this session as well through video. It was conducted in a rural setting in Kenya in an antenatal care context in Nyanza, the former Nyanza province. It also involved provider training, capacity building of providers, and supported referrals. So clients that were identified as being IPV positive were referred with a community referral person or a community resource person. So they were escorted for their appointment so that they wouldn't get lost in the system. There are a number of key results. I'll just highlight 1 or 2. First of all, 37% were reported to be experiencing gender-based violence or to be at risk for it, and the majority of these were successfully referred. And the study also concluded that IPV screening by providers is feasible. Next slide, please. And this is a study where I really want to zone in because this is a population council study that I was involved in. This also took place in Kenya, except in an urban setting at Kenyatta National Hospital. And screening was carried out in the antenatal care, HIV comprehensive care, and youth center settings, which the youth center at Kenyatta National Hospital is a youth-friendly HIV and reproductive health sort of clinic. The intervention involved training providers to screen routinely for intimate partner violence and then supported referrals. So in other words, there was a client advocate stationed at the hospital to escort clients that were identified in any of these 3 clinics to the GBV clinic on site within Kenyatta National Hospital so that the clients wouldn't get lost in the system. We conducted in-depth interviews and focus group discussions. The in-depth interviews with clients, clients were categorized as either being compliant, meaning they were identified through screening, they were referred, and they did go to the GBV clinic, which is where they were referred to. Non-compliant, meaning they were identified through screening as experiencing IPV, they were referred, but for whatever reason, they did not end up at the GBV clinic. And we also collected service statistics. Next slide, please. In the beginning, providers were very doubtful that any client would ever open up and admit that they were experiencing intimate partner violence. But as you can see for the quotes up there, they ended up being surprised that actually when you do ask 3 simple questions, trying to figure out whether clients are currently experiencing sexual, physical, or psychological intimate partner violence, clients actually do respond. Next slide. So we found that clients were indeed willing to disclose IPV despite all the sociocultural barriers that we can think of. So this basically summarizes the whole presentation. A total of over 1,200 were screened and documented because providers were documenting those who were actually identified. Of these, 8% reported reported experiencing intimate partner violence. Of these, nearly 80% were referred to the Gender-Based Violence Recovery Center, and of these, 40% actually did report to the Gender-Based Violence Recovery Center. I should point out that over a third, 38% of these clients that were identified were actually young people in the age range of 18 to 24. This was disproportionately high because clients in this age range only made up about 3% of the total number of clients screened and documented. Next slide. So we do have a problem with young people and intimate partner violence. Clients were willing to disclose IPV once again, and this breaks things down further. The majority of clients reported experiencing psychological intimate partner violence. followed by sexual, intimate partner violence, and physical. We also were interested in the proportion of clients who are experiencing two or more forms of intimate partner violence at the same time, and this came to 62%. One thing I should point out, apart from the fact that sexual IPV was more likely to be reported by young people, is the fact that clients from the HIV Comprehensive Care Center were more likely to experience composite IPV. So when you look at polyvictimization, that number, a lot of the women there are actually HIV positive women, the majority of them. Next slide, please. So providers also demonstrated capacity to screen and refer. Well, I talked about that earlier, but I think what I wanted to highlight here again is the proportion of clients, HIV positive clients again, within the CCC clinics. When you look at the proportions as opposed to the numbers, what you see is that the proportion of clients that were identified was highest at the CCC clinic. Next slide. The referral systems were largely operational, and this really had to do with having a client advocate within the intervention, because with Kenyatta National Hospital being really large, it would have been really easy for clients to get lost. And so having an advocate there to escort them from, let's say, the ANC to the GBV clinic really helped us in terms of ensuring that they made it to where they needed to go. Next slide. And confidentiality is also always an issue with these kinds of interventions. What we found is that clients were really satisfied with the level of, they were mostly satisfied with the level of confidentiality. Yes, next slide. But still, it was not perfect. This is not a perfect story. GVV training is needed at all levels, starting from the receptionist all the way down to the cleaners, whoever is involved within the GBV clinic. As we see here, from 2 out of the 36 clients that were compliant, there were some confidentiality issues with maybe a receptionist talking about, basically outing a client in terms of, why they came to report for services, what they were reporting about, and so on and so forth. The receptionist asked me some of these questions loudly. I told him to be soft because some of these things are too personal and I don't want other people to hear. I told him to ask me softly like the counselor who had talked to me, and he said he's not a counselor. So we had a couple of these incidents, which shows that the training needs to be at all levels, and it was done at the receptionist level, but this receptionist had been transferred, and so this was the new person who hadn't participated in the training. Next slide. Client satisfaction with IPV services was high. There's not enough time for me to show you all the quotes from these clients to talk about how much the women just appreciated having someone to talk to them, which goes back to the point of, who defines benefit for a client that's receiving IPV services. A lot of the women talked about how, listen, I just want someone to talk to. I don't want my marriage to end. I don't want you to send me to a lawyer to talk about, taking my husband to court. I just want to talk to somebody. And when they were given that opportunity, it really brought a lot of relief. Next slide. But there was still a relatively lower referral uptake rate when you consider the proportion of clients that were identified, the proportion of clients that were then referred, which was 77%, and then you have a referral uptake rate of 40%, only 40% of these women made it to the clinic. You see that there's something that's actually going wrong. So we looked at the reasons. Remember, we interviewed both compliant and non-compliant clients. So when you look at the 29 non-compliant clients, that is those that were identified and referred but did not make it to the GBV clinic, what we find is that a lot of the reasons were mainly systemic and mainly resolvable. For example, a lot of the reasons had to do with the way in which GBV services are organized within this particular hospital. The clinic is only open on certain days. If you're referred after hours, you won't find anyone there. If you're referred during lunchtime, you may not find anyone there. So these were some of the issues. We discovered that a lot of these people who were categorizing as non-compliant were actually compliant. It's just that the system needed to be tweaked a bit to ensure that they actually received their services. And in some cases, providers didn't refer, and the majority of those strokes you see there come from the antenatal care clinic, which emphasizes the point that screening may be a great idea, but we shouldn't screen everywhere. Out of all the clinics involved in this study, the antenatal care clinic was the one with the high volume, with a high volume of patients, really high volume of clients, and providers would often would screen and then sometimes rush off somewhere else and then forget to refer. Next slide. So in conclusion, despite some imperfections in the screening process, routine screening for intimate partner violence is feasible even in resource-constrained settings, and it was also highly acceptable to clients and providers. And as for the systemic issues that could help enhance IPV referral uptake, those issues were largely resolvable. Next slide. I don't think I have enough time to talk through the recommendations, so we'll just go to the next slide. So to screen or not to screen, I think that in East African settings, at least based on the studies that have been done on this issue, I think the jury is still out. I think it's too soon to say we should not screen. From the perspective of women and what they want, this is a service that a lot of survivors really seem to appreciate. There was not one that didn't find this, almost life-changing. And I think that that should be enough for us to at least continue to explore this issue. Next slide. Dr. Odongo will be talking tomorrow. Dr. Odongo from the East Central and Southern Africa community will talk a bit more about how some of these results are being utilized. But let me just say that we are engaging with the EXA Health community to carry some of these findings forward. Next slide. Next slide. Thank you.
Thank you very much, Chichi, and thank you for being within time. To screen or not to screen. I think the presentation that she's made calls for the domestication of the international conversation. So what is going on, can we put it to test within the region and see, despite the fact that she's in the jury is still out, I think the point she's making is that we need to interrogate this international conversation. I think also the issue, what she called the surprise, that women were willing, or people were willing to disclose. So sometimes we think this is too private, people will not disclose. And I think a lot of these have agency, and I think we need to appreciate that bit.